Morning, everyone. We are meeting yet another session, 30th August 2025. Have Dr. Rajoo Singh Chhina. It's my privilege to introduce as a director and head of gastroenterology at Fortis Ludhiana Hospital. He is a governing body member of NBEMS and AIMS, former Dean Academic at Dayanand Medical College in Ludhiana, and a past president of several national gastroenterology and nutrition societies with over 135 publications and prestigious award, including Sardar Vallabhbhai Patel Award and a visiting professorship at leading institutes such as Mayo Clinic USA, University in Japan. Dr. Chia is a highly respectable authority in this field. We are here to talk about non-alcoholic fatty liver disease and NASH. Sir, over to you.
Good morning, everybody from India. For our visitors on the webinar who are from outside the country. First of all, I bring you greetings from India and our hospital, Fortis Hospital. And to start with, I pray for the well-being of all the individuals who have been affected by floods in our area. I would be talking to you about MASLD. MASLD stands for metabolic dysfunction associated steatotic liver disease. It's one of the entities which has been changing names. It was fatty liver, NFLD, NASH. It's come up to it. We'll discuss how it goes about. Now, what is basically MASLD? It's a new name for an old entity, you may say, but there are certain changes. So what are the changes? The presence of hepatic steatosis, that is fat in the liver, in conjunction with at least one cardiometabolic risk factors, and in the absence of harmful alcohol intake. Alcohol intake means high amount of alcohol intake, and other causes of fatty liver is termed as MASLD, or metabolic dysfunction associated steatotic liver disease. This definition is a change because it marks a shift towards an inclusion-based diagnosis, which is focused on metabolic dysfunction as the primary driver of the disease. Now, once we talk about the global prevalence of this disease, you can see in Southeast Asia, 33.07%, and a very high incidence in prevalence in Latin America, that is to the tune of 44%. What you can see from the right of the chart is that the prevalence is gradually rising over the years. And if you see the global prevalence of this disease in association with diabetes, all of us know that diabetes is increasing all over the world in its prevalence. So similarly, MASLD, which has got a very intimate link with the metabolic disease of diabetes, is also rising. And if you can see on the right side, the incidence, the prevalence is rising manyfold. Now, the important thing in the global prevalence of MASH vis-a-vis the diabetes is that it is estimated that roughly about 40% of diabetics, 30 various studies on this, 30 to 50% of diabetes are having this disease. So it becomes very, very important because the prevalence of diabetes is humongous in the world. Now, basically, we'll start with how was it? It was almost 200 years ago. You can see in 1836, fatty liver was first discovered. We are now in 2025, so it's 190 years ago. The changes came about. If you see in 2020, the name was changed to metabolic associated fatty liver, which is commonly followed at many places. In 23, the name has changed to metabolic dysfunction associated steatotic liver disease. I'll go more into details, but this is the multi-society Delphi consensus on this. If you see, there has been a change in the name only, NFLD, MFLD, MASLD. But basically, the whole concept is that it revolves around a nomenclature. I would have liked to call it, if you see this, I would have liked to call it MDASLD. I jokingly tell my residents that would have been metabolic dysfunction, and ASLD stands for obviously the American Society of Liver Disease, but they have conveniently taken out the D and they are just calling it MASLD. Now, if you see here in this diagram, it is very clear. If you have a fatty liver, it can be metabolic dysfunction associated liver disease, which is called MASLD. And this further leads on to MASH when there is inflammation, which can further lead on to cirrhosis, which can further lead on to HCC. But if you have alcohol associated fatty liver, it is called ALD. If you have other etiologies like drug induced or celiac disease or anyone else, you have the other specific etiologies of fatty liver. The thing which has changed is this. If you have a fatty liver with a low amount of alcohol intake, that is 20 grams per day in female and 30 grams per day in males, it is called MASLD or uh, alcohol related MAFLD. So this is the change which has come about. Now, if you see here carefully, the important thing is you must have fatty liver, plus you must have one of the criteria in the cardiometabolic criteria. The patient should meet at least one of the cardiometabolic criteria for metabolic dysfunction. If you have this, then are there any other causes of steatosis? No, then it is MASLD. If you have a little bit of alcohol intake, it is MET ALD. And if there are other causes, then it is obviously the other reasons for steatosis. Now, I will just go a little bit into this. These are the criteria. Any one of them has to be there. A BMI more than 25 in Europeans, 23 in Asians, a fasting sugar of more than 100, a blood pressure of more than 130 by 85, plasma triglycerides more than 150. Any one of them is present, we say, in addition to fatty liver, then you call it MASLD. Now, the important thing is, if you see this busy slide, you have a fatty liver and presence of any of the cardiometabolic events like which I told you. If the answer is yes, then you take history of alcohol. If the alcohol consumption is less than 20 in women and less than 30 in men, then it means you are dealing with metabolic dysfunction associated steatotic liver disease, MASLD. Now, we will not go into the details. This slide only shows you that from the normal liver, you get a fatty liver. When you have a fatty liver with inflammation, it is called MASH, and it can turn on to cirrhosis, and this cirrhosis can further go on to HCC or hepatocellular cancer. This slide shows us how the thing is happening. If you see the left of the slide, the left upper part, this is the part. If you have a physical inactivity and you have good diet means not balanced diet or good diet in the true sense, but heavy diet in terms of processed foods, burgers, and things like that, which the Western population seems to be savoring all these days, then there is obviously inactivity and increase in the food leads on to a weight gain. This weight gain further leads on to what we get is a visceral adiposity and central and peripheral insulin resistance. This in turn leads on to increase in free fatty acids, increased glucose, and increase in type 2 diabetes, which further leads on to decreased beta oxidation. So this is a whole process which is going on. And what ultimately is happening, the Kupffer cell and stellate cell activation happens, and this leads on to an inflammation in the liver, which progresses to fibrosis, which progresses to cirrhosis, and which can progress further to HCC also. If you see the slide, the lower part of the slide, it shows F3 to cirrhosis. This can happen in as short as 6 years. So if you have a F3 is a ultrasound or a fibroscan related, it is a fibroscan related diagnosis. I'll come to it a little later on it. Now, these are the various things, how the things are happening. It is a multifactorial risk factors. You have genetics, you have type 2 diabetes, you have visceral obesity, you have gut dysbiosis. Uh, a lot of interest is being shown by many of the investigators on the gut dysbiosis and the microbiota, and uh, it is being discussed, and it has been gone through in a very detailed manner all over the world as far as the progression of risk factors of MASLD is concerned. Obviously, unhealthy diet and alcohol lead on to increased ER test, stress, TLR activation, autophagy, and all these things predominantly lead on to a problem in the liver. Now, what are the risk factors for MASLD? The major risk factor is diabetes. If somebody has to ask me, diabetes, that is the major risk factor. The other important risk factor is obesity. There's an epidemic of obesity in the world. Then dyslipidemia and metabolic syndrome. The other associations which are coming up is hypothyroidism, sleep apnea, hypopituitarism, PCOS, pancreatic resection, and all these things. But the important thing again, stress is diabetes, dyslipidemia, obesity, and metabolic syndrome. Now, if you see how does this happen, it is actually a multi-hit hypothesis which goes into the formation of the MASLD. You have the genes, you have the environment, you have the epigenetics. Now, if you see, obesity and insulin play a very important part, and this insulin resistance is responsible for this MASLD through various things: dyslipidemia, hyperuricemia, hypertension, macrovascular disease. There is an interplay of all these things, and an interplay of all these things is leading on to MASLD. This is a multiple hit hypothesis, and you can see very clearly that it is not a single thing which is responsible. You have the inflammatory cytokines, you have a genetic predisposition, you have the gut microbiota, you have environmental factors, dietary factors, and insulin resistance, to name a few. Now, what is the diagnosis? The diagnosis is done for assessment of fibrosis, to assess what is the degree of hepatic inflammation, then to see what is the risk stratification, to look for comorbidities, screen for HCC, and screen for other malignancies. Now, the importance of assessment of fibrosis. Why should you look for fibrosis? Basically, it is the most accurate predictor of overall mortality in MASLD. It is very important for the disease progression, and it is very important indicator for HCC risk. Now, what are the steps? How do you basically suspect that a patient is having MASLD? Most important is, I told you, if there is a diabetes, if there is a metabolic risk factor, BMI more than 23 in Asians, or you have a first degree relative with the disease. Then history of alcohol intake. If the alcohol intake is less than 20 grams in women and less than 30 grams in men, and there is no pre-existing liver disease, you should look for this if you get a fatty liver on a ultrasound. And then on a test, the liver biochemistry, ALT, AST, may be raised. I come to it a little later in the slide. But you have to exclude other causes of liver disease like hepatitis B, C. You should have negative autoantibodies. You should have negative celiac disease serology, and you should have a normal immunoglobulin. The important thing is, on a liver ultrasound, we should have fatty liver. Now, what are the commonly used non-invasive tests? We have the simple test like the FIB-4 score. We have the NAFLD fibrosis score. We have the AST platelet ratio, which we call APRI. Then we have the liver fibrosis test. We have the other tests, which I'll come to a little later. And then we have imaging. In imaging, we have FibroScan, which has come up in a huge way for diagnosis of MASLD. And then we have magnetic resonance elastography. We have corrected T1 images. Then we have MRI, PDF, and the other scores. Now, if you see this slide, liver enzymes are inadequate in assessing MASLD. This is a very, very important statement because abnormal ALT may warrant a workup for MASLD, but it is not sensitive to confirm, rule out, or characterize the disease. So it's very important. Just basing your diagnosis on liver enzymes is not enough. We need to go a little further. Now on ultrasound, what do we do? On ultrasound can identify fatty liver, but it cannot distinguish fatty liver versus MASH versus fibrosis. So MASH is basically a corollary to NASH. It is the inflammation in the liver. So if you see the slide, the fatty liver, the fatty liver is here, which can be picked up on the ultrasound, but this MASH cannot be picked up. The inflammation cannot be picked up. The fibrosis cannot be picked up. Yes, what can be picked up is the last stage, that is cirrhosis, where you can get the ultrasound to know. The in between stage of fibrosis and inflammation is not picked up by ultrasound. So here is where the challenge lies. Now we have other non-invasive tests. One of the commonest tests which we use is the FIB4 index. Now this FIB4 index is very widely used tool. It is age into AST divided by platelet count and under root of ALT. So the cutoff value, you have to remember this cutoff value. This is important because this is going to be very important. If the FIB4 index, which is age into AST divided by platelet count into under root of ALT, is less than 1.3, the risk of fibrosis is very low. If it is more than 2.6, it is almost very high risk of fibrosis. And this becomes the basis for guidelines, whether it is the EASL guideline or the PASL guidelines or the other guidelines. The problem is that if you have a value which is between 1.3 and 2.6, so you just remember 1.3 and double it to 2.6, 7 we can omit. So it is here we have to be a little careful what is happening. So the problem in this FIB4 index is in the elderly, this 2.6 can be decreased to 2. And in individuals with type 2 diabetes, it may not be so clear as it is in other people. But if you have a value of more than 2.67, it has got the patient has got a higher risk of fibrosis and needs to be investigated further. EPRI, as I told you, is AST over ALT into 100 over platelet count. And then we have the other scores. I will not go into the details of these scores. We have the ELF score, we have the ADAPT score. We can go over this. Now, the imaging techniques. This is the latest thing which helps you in the diagnosis and further management of MASLD. Elastography, which is called in common terms vibration control transient elastography, also known as fibroscan. All of you must have heard about it. It is recommended as one of the advanced steps for the diagnosis of MAFLD. And if it shows a KPA value of more than 8, it means there is fibrosis which has to be taken care of. Then we have on an ultrasound a two-dimensional shear wave elastography, which we can also see. Imaging techniques we can have with the magnetic resonance elastography. In a MRI, you see the whole of the liver. In a fibroscan, you see only a piecemeal of the liver. So advantage of MRI is that you see the whole picture and it provides at least equal quality in fibrosis staging as an ultrasound-based elastography. And it is much more convenient with the MRI. The only thing is the cost. We have certain other MRI-based methods like the MR proton density fat fraction, which is important. It is the non-invasive gold standard for hepatic lipid quantification. Then we have the corrected T1, which I told you earlier. It is an indirect MRI-based method for MASH and fibrosis diagnosis. Now, basically, once we combine now the clinical or the biochemical scores plus the radiological scores, we have a combined score. For example, you see the first score, which is a MAST score. In the MAST score, what you see is here, you have a MRE, that is magnetic resonance imaging, plus MRI PDFF. I told you in the last slide that this PDF FF stands for protein density fat fraction. So you have the various methods to diagnose. Then you have the FAST, in which you take the fibroscan plus ASD. Then you have the MEFIB score, in which you will use the MRI plus the FIB4 score. And we have different values for that. I will not be going into the details of the values by which you can diagnose. Liver biopsy still remains the gold standard, but with limitations. It is the imperfect gold standard, I would say, because it's invasive, painful, expensive, mortality is there, sampling variability is there, observer variability is there. I think we need in future liver biopsy, which is done with a non invasive technique. We put in some sort of a laser or something which gives us the picture on the microscope, and the AI is able to tell us exactly what that is the future, I think, in the management of MAFLD. Now, if you see, this is slightly busy slide. This is for the evaluation. If you see here, the primary risk assessment, we do the FIB 4 score. If the FIB, I told you, 4 score is less than 1.3, you don't have to worry. You reassess the patient. If this FIB score is more than 1.3, then you subject the patient to fibroscan. If the fibroscan is more than 8, you go for a GI consult. Or if the fib is more than 2.6. So I told you in the beginning, the fib score, if it is less than 1.3, no reason to worry. Reassess the patient every 1 to 2 years. If the fib score is more than 2.67, send the patient for a hepatology concern, needs to work up on the MFLD score. But if the fib score is between 1.3 to 2.6, you get a fibroscan. On a fibroscan, if the levels are more than 8, send it to a GI guy. If the levels are less than 8, then it is a low risk, then you have to reassess it again. So basically, this slide tells you the management in detail. This is the simpler slide. If you see it is just a repetition. You get a FIB 4. You have first you make a diagnosis that there is obesity plus minus one of the cardiometabolic risk factors, persistently elevated liver enzymes or diabetes. These people are at risk. So you get a FIB 4 test, less than 1.3, reassess, more than 2.6, hepatology referral, between 1.3 and 2.6, get a fibroscan. If fibroscan levels more than 8, hepatology referral. If less than 8, we have to do the same process of reassessment of the patient. Now, coming to the last part, that is treatment. Treatment, I would say, prevention is better than cure, and this is a international dictum. Nobody can challenge that. And I'm convinced about it that if we are able to prevent few diseases, we are better off than treating many diseases. So prevention becomes a very important thing. And the first thing in treatment is lifestyle intervention. And in lifestyle intervention, we have weight loss, dietary changes, physical exercise, discouraging alcohol consumption. Now, if you see the slide, on the left side, we have the weight goals, and on the below, we have this lifestyle thing. So, first, we'll take the lifestyle thing. So, if you eat good food, that means balanced diet, you take plant based therapies, you take olive oil. Please don't cook in olive oil, the Indian food, because the smoke point of olive oil is around 60 degrees centigrade. Indian cooking is done around 80, 90, or maybe even 100. And I tell you this as the Vice President of the Nutrition Society of India. There is a misconception amongst people that you cook in olive oil and you are very healthy. Once the smoke point is reached, the olive oil changes into saturated fats. So, what I'm trying to say is, if you eat healthy food, it is good. You should not be eating this type of food. You should not be taking these burgers, pizzas, and sugar sweetened beverages. Then this is up again up. If you do exercise, whether you're doing a isometric or whether you're doing a isotonic exercises, any exercise is good. And then obviously you avoid smoking, avoid alcohol. Everybody knows this. This is important. So this is the lifestyle modification which needs to be done in MFLD. Now, what are the weight goals? This is very important. If you have a person with a MSLD, liver disease, and a normal weight, we have reached a diagnosis based on FIB and a fibroscan. FIB score is more than 2.6. Fibroscan shows you fatty liver, liver enzymes are raised. You have already made your diagnosis, but the patient is normal in weight. Should he still lose weight? Yes. a reduction in 3 to 5% of the total body weight will reduce the fat in the liver of such persons. But if the person is overweight, why is this point not coming? Okay. If a person is having MSLD and has overweight, a reduction of 5% of total body weight will reduce the liver fat. But a reduction of 10% will improve liver function, and a little more than 10% will improve the fibrosis. So if you lose weight in an obese patient, it is going to help. But if you have people who are very, very obese and cannot control their weight, then you should consider bariatry in class 2 or 3. So basically, this is just a repetition of the whole slide, which is a good diet, physical activity, avoid these things, smoking and alcohol, and then overweight. If you lose 5%, steatosis reduction, 10% MASH and fibrosis reduction, and then you can consider these weight loss drugs, which I'll come to in few minutes, and then even consider bariatric procedures in people who are just not amenable to your suggestions and your treatment protocols. So this slide only shows you that if you have a higher amount of weight loss from 5 to 10%, it helps in everything: resolution, fibrosis reduction, regression. Exercise helps by activating the skeletal muscles. It helps in the liver by increasing the insulin sensitivity, glucose uptake, oxidative stress, ALT levels decrease, adipose tissue, cardiovascular system. All the exercise helps you all over. Now, this is the editorial which has just come last week on 18th August 2025. What is the impact of dietary habits in liver health? So basically, they have shown these people that if you take processed foods, it is very bad for the liver. And the triglyceride glucose waste to height ratio is a predictor of liver fibrosis. So we come now, we done with the exercise. We know exercise is good. We know weight loss is good. And it is very important to keep these things in mind because of the epidemic of diabetes. I think there is an epidemic of MSLD also in the world at the moment, and we should be going more towards prevention rather than cure. That is my take on it. Now, pharmacotherapy, I'll just not go into too much of a detail into it, but pharmacotherapy basically in MASH or MAFLD. So you must have understood now, this is metabolic dysfunction associated steatohepatitis. So this is where the inflammation is. So there are drugs which decrease the fat. There are drugs which decrease the inflammation. There are drugs which will change the insulin resistance, and there are drugs which will help in reducing the liver fibrosis. So if we take them one by one, we have drugs like GLP. GLP would stand for glucagon like peptide 1 agonist. We have different drugs. We have semaglutide, we have tirzepatide, we have retatrutide, and then we have the PPAR agonist. The PPAR stands for peroxisome proliferative activated receptor. We did not go into the details for this, but the next is the SGLT drugs which are available. Then we have the thyroid, which is coming up in a big way. This is thyroid hormone receptor agonist, which is resmetirom, which is coming up in a big way. And these are the drugs which are available, and these are helping in decreasing the fat in the liver. Now, there are certain drugs, almost similar drugs, same drugs are helping also for insulin resistance. And if you see, there are drugs which reduce the hepatic inflammation, vitamin E. This is one of them. The same drugs now, semaglutide, GLP agonist, PPR agonist. Then we have the FG21 analogs, which are coming up a new way. And in liver fibrosis also we have. So basically, all these drugs are helping in one way or the other. And maybe in coming times, we would know exactly whether we combine this with this or we combine GLP with something else, fatty acid synthetase inhibitor. That is in times to come, we'll know about it. So the preferred pharmacological options for treating the comorbidities associated with MSLD are: if you have dyslipidemia, obviously statins. If you have obesity, then semaglutide is very helpful, and a newer drug which is tirzepatide is coming up in a big way. Bariatric interventions to take care of obesity. If you have diabetes, then GLP-1, SGLT2, metformin, a very old drug, and insulin in case you have a decompensated cirrhosis. If the MAFLD goes into a cirrhotic stage, then it is insulin which you must be using in these circumstances. Now, this is one of the drugs which is gaining a lot of attention. It is a selective thyroid hormone receptor beta agonist, resmetirom, and this has been shown to be helpful in reducing the fat in the liver. It is helpful in reducing the fibrosis in the liver, and it is also helping in interfering in the fibrogenesis in the liver, and so it is helpful. And this has been approved by FDA also recently. These are the various trials with this drug. We have a dosage for more than 100 kgs, it is 80 milligrams, 100 milligrams. For less than 100 milligrams, it is 80 milligrams. So we will go into further. We have the PPAR agonist. The mechanism of action, it improves insulin sensitivity. Glucose and lipid metabolism is changed. It reduces hepatic steatosis. The key agents, all of you know, are pioglitazone, saroglitazar, which we are using in great number these days. The new drug which is coming up is lanifibranor. Now we have these are the various studies which have come up with this. Sorry. Saroglitazar treatment is effective, and there is significant difference in SGOT and SGPT, triglycerides and liver stiffness measurement levels after treatment. The drug can be successfully administered for the treatment of non-alcoholic fatty liver disease. This is one of the things which have come up. This is a pan-PPAR agonist, and this has been found to be helpful. There are other drugs. I will not go into the details of their studies. The GLP-1 receptor agonists are there, where now we have GLP-1 dual receptor agonist and triple agonist also. In the GLP-1, we have only the GLP-1. In GLP-2, we have the GLP-1 and GIC. And then in the triple, we have the GLP, GIC, and glucagon. Now, what does all these things stand for? The GLP stands for glucagon-like peptide. GIP stands for glucose-dependent insulinotropic polypeptide, and glucagon, all of you know. The important thing is it leads on to significant weight loss, 5 to 15%, and that is important with these drugs. Now, these are the drugs. I will not go into details for this. The new drug which is coming up, which is getting a lot of attention, is this dual GIP, which is tirzepatide, and we have the newer ones, which is the triple therapy, retatrutide, which is a triple GLP-1 GIP glucagon receptor agonist, which is undergoing phase 3 trials. The important thing is they all reduce the fat in the liver, they reduce the fibrosis in the liver, and they help in reducing the chances of cirrhosis. So this is various trials. This is a timeline. And if you can see in 2024, if you see the slide here in 2024, this here. Okay. These are the drugs which are going to be there in the next few years. And we have to keep a watch on resmetirom already being used, tirzepatide already being used. And these are the drugs which are going to come up and going to be helpful in management of these diseases. Now, semaglutide has been approved by FDA in August 2025. Just recently, these are the names of the few of the drugs. Now, there are individual and combination treatments. There are certain natural products like flavonoids, terpenoids, saponins, polyphenols, alkaloids, whether alone or in combination therapy with all the drugs which I have talked about, is a thing of the future. Now, coming to the one of the last slides and finish in about 2 minutes. What needs to be done for MAFLD? we have to think as a team, as a universal team, that it is not a good thing which is happening. And why is it happening? It is happening because of obesity. It is happening because of sedentary lifestyle. It is happening because of food intake and diabetes, which is going out of proportion, and it is leading on to, it has already become one of the major causes of deaths due to liver disease in the West. And I am very sure in the near future in Southeast Asia and other parts of the world also, it will become important unless we take preventive steps. Now, how can AI help us in the management of MASLD? If you see this slide, there are many things which comes to my mind how AI is going to help you. AI can help in digital pathology, give faster reports. AI can help in ultrasound imaging, where observer bias is taken care of. AI can help in CT and MR imaging. AI can help in chat box. In chat box, you can go to the public, you can talk about awareness, and there is a dictum in preventive medicine, and the dictum goes that CAP, it goes by the mnemonic CAP, KAP. Only if there is knowledge, the attitudes change, and only if the attitudes change, the practices and people will change. Then obviously AI will help us in further drug developments. Deep learning and machine learning is going to come up in a large way for these things. These are few of the slides which shows how AI is going to take over the medicine, bring it from the bench to the bedside, and it is high time we moved over to personalized medicine rather than a generalized medicine. What I'm trying to say is one shoe fits all sizes is not going to be correct in the next next few years. We are going to have your own the AI is going to check a person. We are going to calculate their genetic load. We are going to calculate their microbiota. We are going to calculate their enzymes. We are going to calculate their ethnicity. We are going to calculate their family history, and only then drugs are going to be given for people. And I am very sure that in coming years, the diagnosis with the AI models, the management in the AI models is going to become better. And very soon, um, I am dangerously optimistic about it. Dangerously optimistic means that I always think things can be done and things will be corrected. And I am very sure in coming years, MSLD will not be a Scrooge on the humanity anymore, and we'll come over it. Last but not the least, I'll just summarize what is MASLD. If you have fat in the liver, it is steatosis. If you have inflammation, it is MSLD MASH. And if you get fibrosis, it is cirrhosis. How does this happen? It is excess fat, insulin resistance, oxidative damage, and loss of other multi-hit hypothesis. How big is the problem? Humongous, huge. 30% of the people all over the world are affected by this. 50% of diabetics are affected by it, and it needs our attention immediately. What was it is the second leading cause of liver transplant in non-HCC patients, at least in the US. What populations are at risk? Obesity, diabetes, dyslipidemia, hypertensive, and Hispanic heritage. How to manage patients? Well, at the moment, it is, I would say, a tricky proposition, but lifestyle modification, weight loss, yoga, meditation, exercise, aerobic, anaerobic, any sort is going to help people remain fit, remain free from the disease, and always remember prevention is better than cure. With this, I thank everybody, and if there are any questions, I'd like to take them up.
Excellent and a much needful presentation about fatty liver, non-alcoholic fatty liver. We would open the forum for question answer, so we can close the slides. Yeah, thank you so much. So we have Dr. Chong here.
Hi, Saurabh.
Yeah, hi.
Thank
Hi,
you.
Dr.
Thank you, Dr. Rajoo Singh for that wonderful presentation on fatty liver. It's a huge problem here in Singapore as well. And we always are in a dilemma to figure out who's at risk for cirrhosis and steatohepatitis, as opposed to just being simple fatty liver. Really challenging situation. I'd like to have questions from the floor, please. Thank you.
Obviously, I understand that it's a worldwide problem, and the worldwide problem starts from obesity. The worldwide problem starts from diabetes, and the worldwide problem it is happening is because of the sedentary lifestyles we are getting into. We are getting into mobiles, we are getting into televisions, we are getting into cars, and we are getting into our, increase in our lifestyle index, I would say. The people who were probably 200 years ago were walking to their work, didn't have mobiles, were eating good food, and probably had less of this disease. So it has a lot to do with the lifestyle changes which are happening across the globe.
Thing is there any clinical pointers that you come across that may be helpful for us to figure out who's at risk for NASH versus let's just simple fatty liver?
Okay, I showed it in the slide. 4 things you must immediately think of a fatty liver. If the patient is obese, 1. If the patient is diabetic, if the patient has dyslipidemia, you must, in these 3 conditions, think of getting an ultrasound and a liver enzyme. So these are the 3 conditions in which you must immediately think about it. Any obese patient, any diabetic patient, any patient with dyslipidemia, think that the incidence of MAFLD is going to be high and investigate the patient.
The other day, I was talking to one of my gastroenterology colleagues, and I asked him this exact question. And he said that there's a group of patients, very interestingly, he says that just cannot fast, just cannot do any fasting. And he says that this group seems to be the one that at risk for NASH. He says they just have a lot of difficulty doing fasting, any sort of fasting, especially for blood tests and procedures and so on. Your thoughts?
Scientifically, I don't think so. If somebody cannot fast, we have clinical evidence or scientific evidence to say that this person cannot undergo intermittent fasting or fasting schedule, so he is likely to develop this. Maybe we need to look into it because these people will have more of glucose craving and things like that. But at the moment, scientifically, if you see the 3-4 things which predominantly make you think that the patient may be a candidate is how do you pick them up? Basically, how they are picked up. They are picked up on a routine LFT. They are picked up on a routine yearly test which they do for your corporates. They are picked up routinely on an ultrasound, which people get so often done. So, but if a patient, I still feel if a patient is obese, if the patient is diabetic, or the patient is dyslipidemic, please investigate the patient for MAFLD or steatohepatitis. Yeah.
Thank you very much, Dr. Singh, for your answer. Any questions from the floor?
What we have an under observation is that the liver is probably a self-cleaning organ itself. So probably detoxifies itself. So when we eat a diet food, like probably a lot of fruits, lot of vegetables, lot of high fiber food, probably healthy food, does it help in terms of cleaning the organ, or it just gives a break to the liver, and you're just helping the liver to detoxify the whatever fatty liver it is?
See, it is a very complex thing. The liver is a factory. It helps us in accumulating many things. It helps us in making many things. It helps us in detoxifying many of the toxins in the body. So it's got a multifactorial role. But I showed you that if you have a lifestyle modification in terms of taking food which is balanced, which is high in vegetable content, very high in antioxidants, and it is good value food which you are taking, then obviously the incidence of fatty, this is a multifactorial thing. It is an environmental thing, it is a dietary thing, it is a genetic thing. But one of the things is the dietary things. One of the things is the dietary. If we take care of that, it is going to, that doesn't mean a person, if he takes good diet, will not get this. But yes, the chances of his getting fatty liver disease in relation to a person who has all the, all the risk factors, plus he is not taking a good diet, is much less, becomes less.
So you mentioned about the oil. Olive oil doesn't need to be used for cooking. There's also where people say that in the morning, if you drink water and probably, if it's a plain water, or if it's a lemon water, or if it's a some kind of a seed water, will that help to clean the liver, or will that also is just a support?
I think these all things are supportive, and people have found them to be helpful. And I say this as Vice President of the Nutritional Society of India, that we these are all myths which are going around. Take this, take this, take this. Scientific evidence is sketchy on these things, but obviously the old age wisdom, the olden traditional system of things which we had, I think we need to relook into it, and we need to refocus ourselves and microscopically examine those things again, and maybe we come up with certain answers, and we are able to do this. For example, in the Indian setup, many people in the morning take tulsi and lemon, and tulsi and lemon have found to be helpful with haldi. If you see curcumin, these days is being used very extensively for even prevention of cancers. Curcumin, I'm very sure, if it is used for even fatty liver and diabetes, may be helpful. I don't know the answer, but there are certain things which are helpful. For example, people do not even know that a simple thing like wheat grass, if you take 30 ml of wheat grass, the antioxidants which you get in 30 ml of wheat grass is equivalent to almost 1 pound of green leafy vegetables. So obviously these things are helpful, but these need to be worked up. I delivered a lecture on farm food versus farm food, that is pharmacology. So it was basically the foods which are available in nature to us need to be relooked into. People are already working on it. And I'm very sure that these vegetables and fruits and antioxidants and other things go a long way in preventing many diseases. Processed foods, heavy foods which are high in sugar content, foods which have a lot of salt, preservatives, are the things which are really causing a lot of problems.
Thank you. Can I welcome for please?
I cannot hear somebody is making a comment, Saurabh.
Yeah, Dr. Monica.
Yes, Dr. Chhina, thank you for a great presentation. So we talked about two extremes. We talked about prevention, looking at lifestyle modification, common sense. You gave some very unique pearls in your role in talking about the heating point of oils and relooking at olive oil, for example. And then we talked about the actual pure manifestation of the liver disease. What is the clinical scenario? You also talked about looking for looking for diabetes, looking for obesity, looking for dyslipidemia. But you talked also about these screening tests, these corporate physicals, routine blood tests. What do you do in the scenario where somebody doesn't meet the BMI criteria of obesity, doesn't meet the criteria for diabetes, but you've noticed now with comparison trends that the BMI is going up, the LFTs are mildly elevated, you haven't fully met the criteria for everything, but we're now in that window where we're starting to see a shift towards this liver disease, and we can now employ these dietary and lifestyle modifications. What has been your experience in actually having lifestyle modifications like exercising 150 minutes a week, about like losing weight 10 to 15% of your body weight? How successful have you seen these measures? Or do you feel that given our genetic predisposition towards the metabolic syndrome, that it is worth starting some pharmacological therapy in addition to lifestyle modification for these early scenarios? What is it that the majority of these people that we're going to be catching on these screening tests, what should be our approach to them given our genetic background?
Very thoughtful question, Monica. See, the first thing is I talked about the predisposing factors. There is another entity known as lean mass. I deliberately did not go into it. That means the body weight is normal. You don't have metabolic factors. Still, you have a fatty liver. So you are just the patient is just getting a routine test done and OTPT are high. Now, in these patients, weight loss helps. Even in these patients, weight loss help. Even if they are of normal weight, a 3 to 5% weight decrease will help in these patients. One. Two, people who are predisposed, the Indians, should we go into a prophylactic pharmacotherapy? I don't think so. Because, see, I firmly believe what is pharmacotherapy? Pharmacotherapy in allopathic sciences is chemicals. It is chemicals. And we are talking about things which we know. And I am very clear in my mind that we are just, like Einstein said, we are just at the edge of a sea collecting pebbles, and the sea of knowledge is in front of us. For example, we really don't know what is the effect of pharmacotherapy on the microbiota which we have. 10 raised to power 13. That is more than a football ground full of bacteria inside you, living organisms, changing your hormones, changing your peptides, changing even the way you are thinking. So these things, then this is the load of bacteria, 3 times more load of viruses in our body. So what I'm trying to say is we are just at the tip of the iceberg in understanding what is happening in our body. We should be going as much as possible into natural things as possible. Exercise doesn't take anything away from you unless you are having a triple vessel disease and start getting onto a treadmill and pop off on a treadmill. Please don't do that. But otherwise, exercise, isometric exercise, eating less, having intermittent fasting. Well, the Nobel Prize in 2016 went to a Japanese a guy, a scientist on intermittent fasting and autophagy, as all of you know. And this was regarding the cancer cells getting killed by intermittent fasting. In India, intermittent fasting has been done for millions of years, millions of years. वो जो करवा चौथ रखते हैं, शिव जी का व्रत रखते हैं, सैटरडे को हनुमान जी का मंगलवार को रखते हैं. So you see, these people had a scientific reason for doing things, and over a period of time, I would say the qualified people amongst us, I would not say the knowledgeable or the wise people, qualified people amongst us thought that all these things were done as a matter of fact, as a matter of ritual, as a matter of superstition, but they had a scientific basis. I firmly believe in that. A simple thing like even eating on floor, sitting cross-legged, you eat less, you bend down more, you will have better family ties once you sit in the kitchen and have food like that. But we changed that to the Western philosophy, and we got into the got into the dining rooms and dining tables and breakfast, lunch, and dinners. Olden times, the Indians almost all Indians I recollect or I have read about ate only food twice, in the morning once and before sunset the second time. So this is the influence of the Western culture which we have on ourselves. I'm not saying everything in the Western influence is bad. I have a car which can drive me fast. I have a probably aeroplane which can get me to places. Tesla is coming up with rockets which will take you to space. But what I'm trying to say is the age-old wisdom, the traditional wisdom needs to be revisited, and we should be trying to do things which do not have side effects. And pharmacotherapy, to me, today we know few of these drugs are helpful. We don't know what are the long-term consequences. We don't know what are the consequences which is going to happen on the progeny 50 years from now, 100 years from now. We have short-term studies, 10 years, 15 years, 20 years. So that is why I think that if we stay on with the natural things and we stay on with for example, what is yoga? Yoga is just I would say stretching exercise and an exercise of your mind. So there is nothing great about it. If people do it, it is good. What is meditation? Meditation is just putting your mind to rest. And now, as a gastroenterologist, I can tell you that 90% of the IBS is related to your mind. So we come back to the natural things. We come back to things even in people who do not have clear-cut metabolic syndrome protocols, metabolic syndrome things. Even in them, exercise and good food is going to help them. This is my take on it.
Thank you for your input. I feel that because a lot of the things that you mentioned are things that I think in the Western world are really trying to address. And I think that there are many efforts that are made before starting pharmacological therapy. And I agree with you, it's always better to go back to the basics. But I think what I'm looking for is what is the decision at which point you're going to say that what is the risk benefit ratio that at this point now we need to start treatment. And maybe that's not an answer that we can get right away, right now. It is, sorry about this. It is something that I think is going to be individualized based on the relationship that you have with your patient and what efforts that they have made. But I think it is a great summary again, and a great reminder that we all need to pay much more attention of what we can do ourselves and what doesn't have side effects with it. Thank you.
So, a lot of people say eat. Can you hear me?
Yeah.
Yeah. So a lot of people say eat small, but eat regular. Eat small bites, but probably split your meal from 2 meals to probably like 5 meals or 4 meals, but eat a smaller portion. A lot of people say eat only 2 meals, but give a gap. So that it's not what you eat, it's when you eat. The difference is like you probably need to have a 16 hours fasting, and probably you eat 8 hours so that your metabolism gets stressed, your glucose gets burned out, your fat in the body converts into proteins. You need to feel hungry when you eat. So which part of this is true for the liver and for the body?
Saurabh, I'm sure I didn't put it in my CV that I'm the vice president of the nutritional side of India. So you are asking me all nutrition related, but it's nice that you ask.
Because a lot of people do relate liver with the diet, I would say. That's the question.
I am convinced that eating small, frequent meals is better gastroenterologically for people, especially people who have GERD, gastritis, and things like that. We always ask them to take small meals, frequent meals. For a cirrhotic who has developed cirrhosis with fatty liver and MFLD, we ask them to take a high protein diet, and we ask them also to take a nighttime snack, because these people are likely to go into hypoglycemia. Rest of the things like intermittent fasting and things like that, actually intermittent fasting has not come into the therapeutic protocol of things at the present moment in the guidelines. In future, it may come out into many of the things, But before that, we have to have a proof of that it is helpful. Intermittent fasting, to my mind, helps you. I think it helps, but if you ask me, Dr. Raju Singh, do you have a scientific validated reason that in MAFLD will you suggest intermittent fasting? I cannot answer at the present moment, but common sense dictates that if you have a MAFLD who is going on to cirrhosis, has chances of HCC, and you have an entity like intermittent fasting, which will decrease the chances of cancer to a little extent. I'm not saying totally, to a little extent. Why not do it if it is not harming you? So these things need to be looked up, and like what Monica said, a time is going to come once we are going to be taking the research from the bench to the bedside, and we are going to have personalized medicines. For example, if somebody gets a headache, if Saurabh gets a headache listening to my lecture, he takes a paracetamol. Monica gets a headache, she takes a paracetamol. Dr. Chong from Singapore takes a paracetamol. All three take paracetamol. All people across the universe take, and I am convinced that headaches will need to be managed differently for different people. Maybe nalidixic acid or something else. Ibuprofen is better for some, and paracetamol is not. So we have not reached that stage of personalized medicine at the moment, where our genetic makeup, our microbiota, envirobiota, our total process, which our ancestors talked about. I have not gone into the details of the medical things which we have in our country, but I think they went into the details, further details than what we are going at the present moment in allopathic medicine, and maybe what you are saying is right. It makes common sense to do that, and it's not going to harm anybody if they do it. So anything which does not harm, that is the physician's Hippocratic oath. You should not do anything which harms a person. You can try other things. Yeah.
Thank you, Dr. Raju Singh. Really good discussion today and presentation. Really enjoyed your perspectives, especially those that coming from the nutritional point of view, because that's always something that we never quite emphasize enough on. If there are no questions from the floor, I thank you very much for your presentation, and we look forward to seeing you again here on this forum. Thank you very much.
Thank you, Dr. Chong, Dr. Monica, Saurav, and rest of the people who joined in. And I hope certain things which I said were maybe not to your taste, but taste is something which is going to lead on to more of obesity and more of diabetes and more of MFLD. So untasty things, unsavory things, if they are said in the correct manner and if they're true, should be taken in the right vein. Thank you so much. And I thank Nishita and IGCP and Saurabh for giving me a chance to be with you all. Thank you so much.
Thank you. Thank you again. Thank you.
So thank you everyone for joining this session. We'll see you again next time.
Okay.